who will have a heart attack? Someone who is forming plaque, because how do we have heart attacks? It's the plaque. And so if you don't show any plaque, you're not likely to have a heart attack. If you show plaque, there's the potential. And so, yes, exactly, because you're literally looking at it instead of just an indirect way of looking at your risk factors. You're looking at whether this is manifesting into actual disease or not.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Great to see you two.
Hello.
Yeah, hi.
All right, on the show this week, heart health and your metabolism. You know, as patients of yours, Dr. Cooper, we know that there is a connection between our heart health and our metabolism, but honestly, I'm still a little bit fuzzy about what that connection is and how we best assess our heart health, how we protect our heart health. So we have a lot to get to. I think we should probably start, Dr. Cooper, with just a basic kind of foundation as to why heart health is so closely tied to metabolic health.
That's such a good question. It is tied to it in many ways. And heart health, we also call it cardiovascular health because it also does include things like our blood vessels and our whole circulatory system. So the circulatory system and our actual heart organ are influenced a lot by our metabolism in many, many ways. And that's because our metabolic system influences things like our insulin levels, and our insulin can, if it's elevated, it can cause what's called vascular hypertrophy, like a tightening of the blood vessels, which leads to high blood pressure. It can also cause things like increased cholesterol production and the bad cholesterol, the LDL cholesterol production, as well as a reduction in what's termed the good cholesterol, which is HDL cholesterol, which helps kind of balance out some of the negative aspects of the bad cholesterol. So it influences a lot of that, as well as our triglyceride levels. And then altogether, that can actually contribute quite a bit to our risk of experiencing something called a major adverse cardiovascular event, which could be a stroke or a heart attack. So it's very closely related. And so the stronger and healthier our metabolism is, that is really beneficial both for not only our weight and our diabetes prevention, but also our cardiovascular health and our heart disease risk.
I'm remembering way back to an episode in the beginning when we defined what metabolic dysfunction and metabolic syndrome is. If you could refresh us on that, because it's a category of problems, right?
That's right. And metabolic dysfunction is really encompasses all kinds of imbalances that can occur within the metabolic system, where metabolic syndrome is more of a precise dysfunction, which has to do with a multitude of problems that occur, such as, in order to meet the criteria for metabolic syndrome, you have to have 3 out of a list of like 5 or 6 different things. And so some of those things would be elevated blood pressure, prediabetes is another, insulin resistance is another, elevated triglycerides is another, low HDL cholesterol is another, or fatty liver markers. So if you have 3 of those kinds of things, then you're in a category called metabolic syndrome. And so the specific metabolic dysfunction you have is metabolic syndrome. And metabolic syndrome is good to identify because it's linked to increased risk of heart attacks, strokes, diabetes, fatty liver disease. So it's, some people have metabolic dysfunction that only affects their body weight or might affect their fertility, but doesn't really affect these other organ systems. So they may not be at risk for that. But if you're a person with metabolic dysfunction who does experience any of those other manifestations, then you are at risk. And I call it high risk metabolic dysfunction, the metabolic syndrome.
A while back, I had a heart scan, which was really simple to do. It was not that big a deal. And I'm pretty sure that my insurance paid for a simple one. But I know, Mark, you're having a more complicated, because of course you're an overachiever. So you have to have the more complicated, higher level one that I know is a little more difficult for insurance to pay for, but I know that you're working on that with your insurance company. But the other heart scan that I had was really simple. In fact, when it was over, I was like, that's it? That's the whole thing? Because it was not that different from when they do the other thing, when they put the little gel thing on you and, the CT thing or whatever it's called, and do the little beep beeps. I mean, it was really simple.
Yeah.
But I know that you get a lot of really good information from that, Dr. Cooper. I know that it gives you, what does it give you again? I know it gives you a lot of really good info.
Well, this is the crazy part. These heart scans have been around forever, like almost since I've been practicing medicine, which goes back a long time. And they've been labeled as research for research purposes, although the American College of Cardiology recommends them, so they're not research. They're actually the most reliable test to determine whether you're at risk for a heart attack in the next 10 years. So,
good information to have. Nobody wants that.
It is more reliable. I'll explain what the heart scans are, but they are more reliable than blood tests for your cholesterol panel, even the extensive blood tests that we do, which we can talk about some of the extensive markers, but they're even more reliable than that. So because they are both positive and negative predictors of heart disease. So if you get a scan and your score is 0, meaning they don't see any plaque in there, that is a very powerful, accurate, negative predictor, meaning that you are not likely to have a heart attack in the next 10 years. But if you have plaque, and depending on what the amount is, as it goes up in value, it is the most accurate positive predictor, meaning that you are at increased risk of developing, a major cardiovascular event, such as a heart attack. So it's a very useful test. And the question is who should have it, I guess,
And we should probably define the baseline test that you order for your patients is a calcium scan. And what I think is interesting, Dr. Cooper, is that until I became a patient of yours, I'd never had a heart scan in my life.
No, me neither.
You hear these tragic stories of people in their 40s and 50s who die of massive heart attacks that could have been prevented if they had a simple scan, right?
Yes, it's true. And some of those people have plenty of resources to get tested. But as I said, the heart scan is more accurate than not only the blood testing, but also actually stress testing. So it's more accurate than people who undergo the cardiac stress testing with echocardiograms or even nuclear test studies, even the very advanced ones. It is more accurate than all of that. And so we're really thinking about things in a funny way when we're not putting them closer to the first line evaluation. And it's not every patient necessarily needs a heart scan. So I think that I still really like to measure the blood levels, of course, because that helps you to identify who is at risk. And so the family history is very important, just like everything we talk about with metabolism. Genetics is huge. It's like one of the biggest risk factors is your genetics. Does the person smoke? Because that increases their risk too. Is diabetes present? Because there may be higher scrutiny, if you've got diabetes or hypertension, other what are called comorbidities. But the basic lab work that most doctors do only includes your total cholesterol, your triglyceride level, your LDL cholesterol, which is the bad cholesterol, the HDL cholesterol, nicknamed the good cholesterol. That's pretty much it that most doctors run. And based on that, they're giving advice and saying you're at risk or you're not at risk. But that really doesn't tell you who's at risk. And so we run a more extensive panel, and a lot of doctors do these more extensive panels that you can get that break down the LDL cholesterol, which is the bad cholesterol, break it down further so you can see what type of LDL it is, because LDL cholesterol has different particle sizes, and the smaller they are, the more they will stick to the artery walls. And the larger they are, they float by and they don't stick. And so we can now measure the number of particles you have and also the size of the particles. And so based on that, you get even more important information of whether you could be at risk. And in addition to that, there are other markers that are cardiac risk markers that we look at. One is called apolipoprotein B, and that's getting to become more popular as a screening test. And if that's elevated, there's additional risk that those LDL particles will be able to stick to the artery walls. And there's another one that's a genetic marker called lipoprotein A. It's not a genetic marker. It's actually like something inherited genetically. And if you have elevated lipoprotein A, then that also increases the risk that the LDL cholesterol will stick to the arteries and form plaque, and that you'll be able to form more plaque just based on a lot of different mechanisms. And so it can increase your risk of plaque formation by like 40% if you have that elevated lipoprotein A. So all of these things are important. Even you'll hear about HSCRP, which is an inflammation marker. It's important because if you have inflammation, it's easier to form plaque. And then we talk about adiponectin, which is that beneficial hormone from the body fat that actually acts to prevent plaque from forming by reducing inflammation in the blood vessels. So there's all kinds of stuff you can look at. We're even looking now at something called TMAO, which is like a byproduct of unhealthy gut bacteria or microbiome. And because now we know that that plays a role also in plaque formation and cardiovascular health. So there's so much that you can look at. So the best thing is to identify who is the person that you want to send for the heart scan. So if you look at that whole picture, you'll be able to tell, wow, this person is in the low risk zone for every single thing on this list and has no family history, is not taking a medicine that's making it look this good. So they don't really need a heart scan, most likely, because they're not showing any risk factors. And then you may see another patient who has some of these alarming findings. And so that would be a good person to send off for a heart scan, or someone who has history of people having heart attacks at young ages, in their history, regardless of what their cholesterol panel looks like. So, I think there's some thought process involved in who should get a heart scan. If someone really wants a heart scan, even if they are low risk, why not? It's okay. It is radiation exposure. So that's something to consider because it's a CT scan. It's a rapid CAT scan that's done taking like little slices of pictures through your heart. The test itself takes 30 seconds. So that's why Andrea thought it went fast.
I was like, that's all? That's so quick.
Yep. So you may be in the radiology room for like 10 minutes because they have to set it up and they put an EKG on to time it in between your heart contractions. And what it does, this is the simple one, it's called a coronary artery calcium scanning test, coronary calcium scoring test. Sometimes they'll call
mine, I think it was only $99 where I went.
Yeah, it used to be.
It was crazy.
When you guys did yours, I think it was that. Now they've like doubled the price. But it is kind of silly that it's not covered by insurance because it actually is recommended by American College of Cardiology if you're in those risk brackets to get that scan to determine whether or not, because these other tests are known now to be poor predictors, and this is the best predictor.
Because you're actually looking at the physical structure of the heart and you can see calcium buildup, right? And plaque buildup?
Yes, because, who will have a heart attack? Someone who is forming plaque, because how do we have heart attacks? It's the plaque. And so if you don't show any plaque, you're not likely to have a heart attack. If you show plaque, there's the potential. And so, yes, exactly, because you're literally looking at it instead of just an indirect way of looking at your risk factors. You're looking at whether this is manifesting into actual disease or not. And so that as a screening test is good. And even out-of-pocket cost is not bad now, even though it's doubled. But you could try to submit to insurance now. We have argued with insurance sometimes and been able to get it authorized, and then the out-of-pocket goes down to like $30. The actual test is much more expensive than our out-of-pocket costs when you're paying cash, because they do these deals with patients for out-of-pocket pricing. But that test is a very good screening test. And the level of radiation exposure is less than a mammogram. So it's one of the lowest level radiation exposure screening tests that you can get. I mean, it doesn't mean you should get them all the time, but since they're such good predictors, they literally are accurate predictors out like 10 years, 5 to 10 years. So if it's 0, you really probably don't need to repeat it for like 5 years, unless you have really strong family history or something that really looks alarming. I'm sort of a paranoid doctor, so I do get them more often, I have to admit, but it's totally reasonable to get those every 5 years.
So I guess here's the $64,000 question. Can plaque be reversed if you see it? I mean, there are, I think in the early 1980s, balloon angioplasty became a thing where, they puff up the artery, break up the plaque and get rid of it that way. But can you reverse it medically, chemically, pharmaceutically, I guess is the right term, Dr. Cooper? Can you reverse it?
It's really interesting because we were always told you can't reverse it. But in clinical practice, you do see, if it's a low level, especially very low levels, we do see it. It's called plaque regression. It can reduce. And aggressive medical therapy to get those numbers down as low as possible that are the instigators has been shown to enable some regression of the plaque in some cases. And lately, I've been seeing a lot of scans showing reduction in the plaque burden, which is not what we were told could happen. So, and our patients are like, "Oh, I didn't know it could go down." And I'm seeing more and more of that lately, of these decreases. And it might be because we have this database that fortunately, we've been so fortunate to look at through our nonprofit. Our Diabesity Institute has provided the ability to capture a lot of our data into this database that does a lot of analysis. And based on that, we could see that the panel that we get, it's called Cardio IQ, but it's showing all of the different levels of risk factors, risk levels that we discussed, the ApoB, the lipoprotein A, the LDL particles, all of that. And we were looking at that category compared to other categories that we're tracking, like blood pressure, diabetes, weight, and all that. And this category was not improving in as high a percent of our patients as the other categories. And so we decided to become a little bit more aggressive with our treatment protocols based on that information. And since then, we are seeing these scans showing reduction of some of the plaque burden in those higher risk patients. So yes, you can make a difference. There's a lot of different schools of thought about this plaque, because you'll hear that the calcified plaque is more stable and doesn't tend to break off and cause heart attacks, whereas soft plaque that's less mature is the more likely plaque that can break off or cause problems. And so sometimes you'll see these scores increase over time, and it's not necessarily a bad thing, because it could mean that soft plaque is converting into the calcified, more stable type of plaque. So there's a lot of interpretation you've got to do, but the question was, can you reverse it? And I think you can, in certain cases you can, and we have had some people with low levels that went back down to zero. So it is very interesting. And more these days, they're getting away from just rushing to the balloon angioplasty that they used to do and using more medical treatments because they're seeing kind of equal response in a huge number of patients. There will be some exceptions, but it's also important to do these kinds of things to determine, well, who should have medication to help lower their cholesterol and who doesn't maybe need the medication.
I think my numbers went down. I have that hereditary one, but I don't have the the other kinds. So,
yeah. Yes. Right. The lipoprotein A.
Yeah.
And I think yours did. Your scan,
but mine
I think,
went down.
Did go down. Exactly. Yes. So that's really interesting.
Yeah. And at least you can optimize cholesterol levels and particle sizes and all that kind of stuff,
right.
with medicine.
And the good thing to learn is that it doesn't come from eating cheese and eggs.
Oh, that's important. Yes.
Because that would be just a disaster.
So, Dr. Cooper, you suggested that I have a more advanced scan to try to look for some of that softer plaque or whatever you call it. And so I've got a CT angiogram on the schedule, and I think retail it's about $1,200. The insurance company denied it, and I kind of laughed when I looked at the rejection letter. It said denied because patient does not exhibit signs of heart disease. And I'm like, well, what do you think we're trying to do? We're trying to prevent heart disease by looking at my heart. So I'm fine. And there's a cash discount, so I'm okay with that. But I can't think of a more prudent thing to do because it just takes one event to kill you.
Yes.
If you're, and they call it the silent killer, some of these different types of plaque buildup in the heart. And I just can't think of a better thing to do to have some peace of mind for you and your family.
Or to be preventative. Like the idea that like spending a little bit of money now will save an insurance company, $90,000 to bring you back to life later. Like, I just think it's like penny wise, pound foolish on their part.
Yeah, I feel like the insurance companies are not keeping up with the authoritative institutions, the American College of Cardiology, what they're saying and how we should be doing these workups. It's not translating into what the insurance companies are covering. They currently sometimes won't cover certain very effective medication or these advanced heart scans that are the ones with the dye, which we recommended for you, Mark. That's the same kind of thing as the other, but this time they squirt dye in so they can see the caliber of the artery. So they could tell if there's stenosis, like any kind of crimping down in the arteries due to soft plaque. They could actually see the plaque, the calcification versus the softer plaque. And so that test is just so important, but we're getting denials if the patient hasn't already had a heart attack. So the insurance won't cover unless you've had a heart attack. You can't have that test covered or certain medications that could prevent a heart attack. So
isn't that crazy? I mean, the medical institution, insurance companies look at the human body like a car. It's like, well, did the radiator go out? No, but maybe we should put some new antifreeze in there.
It's so true.
It's crazy.
It really is. So we're hoping that yours, Mark, shows only what we saw on the routine one, which was just the calcified plaque there, and not that you have a whole bunch more soft plaque in there that could be either causing a narrowing or, ready to break off in the future or something like that. And so that helps determine future treatment strategies and whether you need like more consults with cardiology or what. But this will really help, and it could be reassuring. And again, it's a strong negative predictor or positive predictor. And so that's why we would like to get that
and
advanced
you talk
scan.
About family history, and my dad had to have a stent put in, and my grandfather on my dad's side had diabetes. He smoked. He had coronary artery disease. I have vivid memories, just like we're watching TV and he's like, oh, and he just kind of holds his chest, and then he got his pill bottle of nitroglycerin tablet and dissolved it under his tongue. And then the pain would go away.
Yep.
But this is all well before all these fancy scans were
Yes.
around. He ended up
Before.
ultimately dying of a massive heart attack. But
Oh,
it's too bad because, today we have the ability to predict and prevent these things. So Dr. Cooper, for the person who just is wondering, where do I start? Like, what's a good starting point when it comes to assessing your own heart health?
well, I think, look at your family history. There are a lot of calculators out there, but again, those are proven to not be good tools, like the ASCVD calculator, atherosclerotic cardiovascular disease calculator. It over predicts who's at risk. And there's a lot of other little calculators that are not that accurate. So I think the best way is to talk to your doctor about getting an advanced blood panel, especially if you have family history of heart disease. And so these advanced panels are run through various labs, very common labs. So like LabCorp runs something called the NMR lipoprofile, and Quest Lab runs the Cardio IQ panel. There's Berkeley Labs that runs a huge panel. There's something called the VAP panel, VAP. So all of these are panels that look closer at these particle counts, and also you can add on other tests such as the lipoprotein A, the apolipoprotein B, and maybe the HSCRP. There's other tests to add on to it to get a better look than just your total cholesterol, triglycerides, HDL, and LDL. And if you're a person that has hypertension, diabetes, it's really important to look really closely at that because all of these have compounding risk. And so I think starting from that, and then if you're in these elevated ranges, what's really interesting is they are better predictors because they're more detailed, but it still is not as good as the heart scan at predicting who's at risk. So if you're a person that gets your test results back and your doctor says, oh, you need to go on a statin to get these down. Well, it may be true that you might need that, but they're finding out that if you have a heart scan and it says 0, regardless of what your labs say, you probably don't need the statin, which is really hard for me as a doctor to accept that because, I don't like looking at those numbers and I just feel like it's going to cause a risk. But the data shows that if you have a heart scan and it's 0, and whether or not you take a statin, even if you have terrible cholesterol, you're going to be 10 years later at the same place as somebody who took a statin or didn't, as far as your risk. It makes no difference. So I just think it's kind of crazy to think. But if you have plaque, it's a whole different story. If you have plaque, definitely the increasing numbers, the statins and the cholesterol lowering meds, there's a bunch of new ones now. They definitely reduce the risk of having a cardiovascular event. And so in that population, it's marked reduction. And so I think it's one of those things where you just really have to decide. I still do have our patients that have really nasty looking numbers take a low dose medication, even if they have a negative heart scan, until at least we have a couple of negative heart scans and we're sure. And if, they have any family history or other comorbidities, I just figure it's a good insurance policy. There's not really a big risk to taking it, especially if they're in the group that's not associated with promoting things like diabetes. Some of these statins do have the tendency to increase blood sugar levels. So you always have to measure the blood sugar levels in conjunction with the statins and make sure they're not causing an issue there. It's an individual decision between your doctor and the patient, basically.
Is there any truth to the heart healthy cereals? Is there any truth to the better living through exercise and chemistry type of situations? I mean, we all know that exercising is a good thing, but is there truth that if you're running a couple of miles a day that will lower your cholesterol and be better for your heart? Or is that just a good thing all around?
It is true. Well, it is true. We consider it cardiovascular risk reduction, lifestyle strategies. And definitely if we have people in those higher risk categories, we do encourage some type of cardiovascular exercise. And it's really beneficial to mix up the exercise a little bit, because if you get too high in the intensity, it actually can backfire and increase your cardiovascular risk. So we want to keep the intensity in more of a moderate to fairly low zone a lot of the time. And maybe not low, but a moderate range where you can carry on a conversation and not be out of breath and not feel like you're maxing your system out. But that does help because it also, exercise increases the oxygen demand for the heart. The heart is a muscle. In order to contract and keep up with that blood flow needed for exercise, it has to strengthen, it has to take up fuel, it has to burn fuel, take up oxygen and burn fuel. And so that involves improving the circulation to the heart. And so as you're exercising, you're literally stimulating new blood vessel growth, new circulation to your heart muscle to deliver more oxygen to that working muscle through alternate avenues of circulation. So say you did have plaque that was trying to block one area. If you're an exerciser, you may have developed alternate inroads. So you can bring oxygen to that muscle through other alternate pathways. And so you'd be reducing your risk of having a bad heart attack and heart damage if you did have a heart attack by just having that exercise background. So I do think definitely exercise is definitely on the table for people at risk. And we like to look and see what exercise zones they should be exercising in and do more of a medical exercise program. But the other would be the nutrition does play a role. And it is true that some cereals can put that label because soluble fiber, which is found in starchy carbohydrates like oats and barley, is very beneficial for your LDL cholesterol. And so it does lower the LDL cholesterol and improve that. And other foods do too. So keeping up a lot of fruits, vegetables, whole grains, plant fats such as avocados, nuts, nut butters, that all is very good for heart health. And then fish also and omega-3 oils are very good for heart health too. While it is true that a diet heavy in meat intake has been shown to be negatively affecting the cardiovascular risk profile. And it could be not just the fat in the meat, but also the protein and just how it affects our actual microbiome in our gut and the offshoots of that come back and negatively affect our cardiovascular risk. So diet, that's the old school, like diets lower in meat, higher in plants, it's gaining popularity now. I don't think people have to be vegan and all of that. And it's individual. It may not improve it. I mean, we have patients who go from omnivorous diet to a vegan diet thinking that's going to improve it. And we see it didn't improve it. It even may have gotten worse. So it's very individual who will respond to that.
So we're just about at time, Dr. Cooper, but I wanted to just get your opinion on high blood pressure and cholesterol numbers. What are the basic numbers that should tell us that we should get something done if we're in the danger zone? Like, what are the cutoff points?
That's a great question. So the basic numbers, again, it doesn't mean much if you're only getting that surface screening, but it starts to be a red flag if your total cholesterol is above 200, if your LDL cholesterol is above 100, if your HDL cholesterol is below maybe 40, and if your triglycerides are above 150. That's the basic kind of, routine. Mm-hmm. But when you start breaking it down into the particle counts, what's nice is the reports will show you where you fall in the risk. When you get the report back, you'll be able to see there are various tiers of risk based on those particle counts. And so we want low particle counts of LDL, large LDL size. And then when it comes to lipoprotein A risk marker, that one, the lower the better, really. And so it can, especially if it's 300 or higher, it can be very high risk and increase your risk for forming plaque. Apolipoprotein B also. When you get those reports, you'll see the guidelines. We use certain cutoffs that are just based on what we're seeing. And there may be other cutoffs that your doctor wants to use based on your other factors. Like, for example, if you have elevated lipoprotein A and it's 300 or higher, even though the LDL is considered, quote, good if it's under 100, people like that should have their LDL way down at like 50 because the risk is so high. And so you have to take those individual risk factors to determine what's your target range that you should be at based on all of that.
And
then,
blood pressure,
yeah,
120 over 80, is that sort of still the benchmark or no?
Still, a long time ago, they switched the guidelines and it has thrown doctors off a bit because they're very strict. And so what may come out as stage 1 hypertension is not necessarily high enough to put a person on a blood pressure medication because you may be still concerned it would make it too low. So it's a little bit confusing, but it is good to show alarm at an earlier stage than we used to. So below 120, below 80. So 120 is the systolic upper number and 80 would be the diastolic lower number. Those numbers, if it's less than 120 and less than 80, you're in the optimal range, no problems. But then it goes up from there. So then if you go to where your diastolic is still less than 80, but your systolic is hitting that 120 and it's going from 120 to 129, now you're in what's called elevated. And then the next tier is called stage 1 hypertension. And that's when you're at 130 to 139 systolic, and then your diastolic is 80 to 89. And so it goes up from there to stage 2. So 140 over 90 is like more alarming. And then you're really in trouble if you're like beyond that.
I remember when I first came to you, my blood pressure was a real issue. And you got me on some great blood pressure medicine, no side effects. And it's been just amazing how my blood pressure has come down. We're actually starting to reduce the doses now. And
yes,
it's just in a perfectly optimal place. And I know a lot of people are really hesitant to get on medications, but these meds are so effective at reducing blood pressure. Yeah, isn't that crazy?
Well, and if you don't do it, it is putting a huge strain on your kidneys and your heart. So think of it as your heart's a pump, and then, your blood vessels are just the pipes. And so if those pipes are shrinking down, there's a lot of resistance in the system. And then as that blood is flowing through your kidneys, it's coming in at a very high pressure, and it can literally like blow out your kidney cells that are trying to filter your blood. And then it's coming back to your heart at a high pressure. And then your heart is just like having to work harder. And so you can get hypertensive heart disease and kidney disease and all kinds of problems due to that untreated hypertension. So normally you don't treat a single elevated blood pressure, but if there are 3 consecutive elevated numbers, that's enough to start treatment.
Well, this has been super interesting. Heart health and your metabolism. Andrea, what's the takeaway from our discussion?
I think you always get help from medication when you're working on other things. It's not a crime to ask for some help. And also get tested. It's always good to get information. It's just information. Like, why wouldn't you want information? It's always helpful.
I think my takeaway, Dr. Cooper, is that, if you have the ability, if you have insurance or you have enough money to do some of these scans, there's really no downside. And especially, as you said, I have a pretty strong family history of heart disease, and staying on top of this stuff, there's just no downside to knowing your risk. And we see just young people struck down all the time from this stuff that's absolutely preventable in today's age. Dr. Cooper, what's your takeaway from all this?
Well, it's as you say, heart disease is still number 1 killer, men and women. And so it is very true. So we should be doing a lot more preventive work in this area. And I think you do have to advocate for yourself because people may not feel like you're at risk, but if you really want to know, dig deeper. It is true that the heart scans are not as accurate under age 40 because it takes a while for that plaque to calcify. So if you do a heart scan before age 40, you can't be too reassured if it says 0. You have to kind of repeat it. The other thing to keep in mind is that the American College of Pediatrics recommends that kids are screened with the blood levels of their cholesterol, and if there's family history, the lipoprotein A, between age like 10 and 15 the first time. And so we very rarely see kids that have been screened. And so that's another thing. Make sure your kids are screened as well.
Yeah. And we see, quote unquote, healthy people drop dead from heart disease all the time and it just goes to all the other discussions that we've had. You just can't judge a book by its cover when it comes to things like heart disease and all of this other stuff. Well, this has been super fascinating. Appreciate the conversation, you two. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.